My name is Mark Rosenzweig. I am from West Bloomfield, Michigan, but I'm coming live from Chicago, Illinois right now. So I'm remote, visiting my children. So I just want to say that we've had 76 ALKtALKs so far since we started back when 2020. And I was given a report to Katie and it kind of blew me away because we have over 68,000 views on YouTube. So everything that we do in ALKtALK is recorded on our YouTube channel, and it's presented to the group. You can go ahead and view all these, and maybe if something does apply to you today, keep on looking on the YouTube site. You will find the information, I guarantee you. So I've had ALK for 12 years, and I'm going to start answering, launching some polls. Launch it. So it shows up on your screen. It should say, how much interaction have you had with a pharmacist as part of your healthcare team during your cancer treatment? And this will allow our speakers to know who's in the audience. Share the results. Okay, for everybody, 43% has some, 23% has been minimal, 20% significant, 11% none, and 3% are uninsured. So I'm gonna stop sharing that one and go back to our second question. And that is, how many herbal supplements, dietary supplements are you currently taking? Share the results. Okay, top is 46% is 1 to 3, 28% is none, 15% more than 6, and 10% 4 to 6. I'm stop sharing that one and jump into our third question. How comfortable are you managing your medications? So let's show the results. Interesting enough, 43% are very comfortable. 38% are confident. 20% are somewhat comfortable. And stop sharing those. And so I'm going to turn the microphone over to Dana Carito. Dana has been with us probably from the very beginning, art therapy in 2020. And she came on board to our healing arts projects and she runs basically all of our scheduling programs. And I really appreciate Dana's involvement. And normally Summer's here, but Summer's at a lacrosse tournament. It's not a tournament, but it's actually
a banquet. Yeah.
So anyways, thanks, Dan, for coming, and go ahead.
Hi, everybody. I am Dana Carito. I live outside of Philadelphia. Was diagnosed in November of 2020. And I use the Penn oncology pharmacists a whole bunch. And I just, they're really helpful. They go through and, they look at everything I'm taking, and they're really such a resource. So I'm so appreciative that they're coming to give us, some more information about what they do, so that everybody can realize what a great resource they are, and that they should be asking those questions, because there's a lot of things that your local pharmacist is just not going to know, because they're not really familiar with the oncology drugs. So that was it. I just wanted to introduce Corrine and sorry, I'm blanking. And Corrine and Sophia. And I'll just let them give their own introductions. I don't know how you like to be. I know you have PharmDs, and I just don't know I'm not quite sure how to address you. So I'm gonna pass the mic over to you guys.
Okay, we can go ahead and start off. I will get us started. My PowerPoint was not working, so Sophia has gratefully set the screen up for me. Get that sharing. Okay, hi everyone. My name is Corrine Stahura. I am a oncology clinical pharmacy specialist over at Penn Medicine, and today I'm going to present for you Breathing Easier, how a thoracic clinical pharmacy specialist helps you navigate meds and drug interactions. Okay, here we go. So today's presentation, I'm going to be reviewing what a clinical pharmacy specialist is. How does this differ from your typical CVS pharmacist? What our role is in an oncology clinic, and just some basic drug-drug interactions. Okay, so we'll start with clinical pharmacy specialist. So I'll just start with a quick introduction of myself, what I did in order to get myself here. So I went to pharmacy school at Binghamton University, School of Pharmacy and Pharmaceutical Sciences. I did my first year of pharmacy residency training over at Cleveland Clinic Akron General. I did my second year of pharmacy residency training over at Memorial Sloan Kettering Cancer Center. I very recently have passed my board certification, so I am now considered a board certified oncology pharmacist. And my current position, as I stated, I am an oncology clinical pharmacy specialist at Penn Medicine in Philadelphia. Starting off, I wanted to just go over what types of pharmacists there are in the world. So when everyone thinks of a pharmacist, they tend to think of community pharmacy. So this, for example, could be your CVS, your Walgreens, Rite Aid, in your grocery stores like Wegmans, which is my favorite grocery store, or independent pharmacies. Here, pharmacists typically dispense medications, offer health advice, provide any pertinent counseling when they have time to, and really support patients in managing their health and medications. Next, we have clinical pharmacy, which is where Sophia and I are. Here, we're talking places like Penn Medicine, Cleveland Clinic, Jefferson, or like a private doctor's office, for example. Here, we collaborate with healthcare teams to really optimize medication therapy, ensure safe and effective use of drugs, and monitor patient outcomes to improve patient care. And then lastly, we have pharmacists that actually work in pharmaceutical industry. So big drug companies like Merck, Pfizer, AstraZeneca, Johnson & Johnson, et cetera. They focus on drug development, clinical research, regulatory affairs, drug safety, and kind of like building and making these medications. But today we're really going to be focusing on clinical pharmacy. And even within clinical pharmacy, there are different types of pharmacists. So we have our staff pharmacists. These pharmacists typically dispense and verify medications. They review drug interactions and dose appropriateness, and also manage the medication inventory. So you may have run into these pharmacists before in your infusion clinic, for example, dispensing your chemotherapy. Next, we have clinical pharmacists. These pharmacists monitor patient medication regimens and adjust therapy. They perform medication therapy management and clinical assessment with an interdisciplinary team, and they also conduct patient education and counseling. Next, we have our clinical pharmacy specialists. So that is what Sophia and I are. We are a basically more specialized version of clinical pharmacists. So we lead specialized care teams in managing complex medical conditions or patient populations. We are more expert level consultation for that medication therapy management. We oftentimes will even participate in clinical research and different research studies on our campus, and we will develop therapeutic protocols and even mentor other pharmacists such as our residents and students. So what type of education do you need to get in order to become a clinical pharmacy specialist? So as of now, you could get a bachelor's way back in the day, but I think over the past 20 years, a doctorate of pharmacy is required. This is typically done with 2 to 4 years of undergraduate prerequisite classes, and then followed by a 4-year degree that really focuses on pharmacology, patient care, medicinal chemistry, law, and ethics. To become a clinical pharmacy specialist, you have to do your first year of residency. This is kind of a more broad internal medicine type residency. It's 1 year long, and we have clinical rotations across all different types of clinical settings: inpatient, outpatient, different specialties. During this time, we do projects, presentations, research. There's teaching opportunities and mentorship. And then lastly, we are required to do a 2nd year of residency where we specialize. In both of our cases, we have specialized in oncology. This is once again an additional year, so 1 year long. We typically have clinical rotations only within oncology, so really focusing on specific different types of cancer. But we still have all those same projects, presentations, research as we did in our first year of residency. Okay, so between the 3 different general types of pharmacists within clinical pharmacy, there's a little bit differing types of education that is required and the location in which you will find these pharmacists. So staff pharmacists, typically it is just a PharmD that is required, so just the degree. Typically no residency or any form of board certification is required. Typically, you will run into these pharmacists as an infusion pharmacists, either making those chemo, verifying the chemo, getting it out to you in the clinic, or in central pharmacies and hospitals dispensing medications. Clinical pharmacists, these pharmacists typically have a PharmD. They typically have about a year of residency training. Sometimes they are board certified, typically not in a specific type of clinical practice, but it is a board certified pharmacotherapy specialist. And they are typically in hospitals on the patient floor themselves, or they can be infusion pharmacies and they will actually go out and counsel patients as well. And then lastly, there's clinical pharmacy specialists. Typically we get our PharmD, we get those 2 years of residency training, and then typically a board certification is often required. And the type of board certification depends on the specialty. Typically, we work in clinic with the providers in the outpatient setting, and then on the inpatient setting, we work with a rounding team of physicians, advanced practice providers such as physician's assistants or nurse practitioners, nursing staff, etc. Okay, and then we'll go into our role as clinical pharmacy specialists. So we kind of have 2 big roles, one within patient care, and then another just kind of outside patient care, other responsibilities that we have. Within patient care, we typically review your chemotherapy, or since most of you are ALK patients, targeted therapy, supportive care, and home medications. We adjust for doses based on labs and organ function. We check for drug interactions and side effects of medications. We provide medication counseling, kind of what side effects to expect, how to specifically take the medication, whether that be with or without food, separating it out from any other medications. And then we also answer medication questions from both patients and our providers. Other roles that we have, we present new drugs at big pharmacy meetings where we determine if we want to add it to our hospital's formulary or not. We manage medication protocols and policies, as well as we teach pharmacy residents and students. So I think this is a really important slide that I really want you all to focus on. So I want you to know when to reach out to us and when to reach out to your oncologist or your clinic nurse with different symptoms or questions. So when to reach out to us, your clinical pharmacy specialist, when you have questions about how or when to take your medications. Please reach out to us. We can definitely help you with that. When starting a new drug or supplement, whether it be an oncology drug or honestly any drug, we want to, make sure that that drug is safe with your current cancer treatment regimen and make sure that there's nothing interacting. If you're experiencing any side effects and want to know how to best manage these, this can be also routed to us. Excuse me. Feel free to reach out to us. We really know best how to manage all of these, kind of typical side effects that we see with a lot of these agents. And then if you do need help facilitating refills, we, in our role, I'm not sure with other types of clinical pharmacy specialists, but we work very closely with our specialty pharmacy at Penn and can help coordinate some refills, or if you're having any insurance issues, et cetera, we can kind of coordinate you over to our specialty pharmacy. And then when to reach out to your oncologist or your oncologist's clinic nurse if you have a sudden change in your symptoms or side effects, such as fever, pain, or shortness of breath. Kind of those more severe symptoms that we're not sure if you should either come into urgent care or go to the ER. Some things that are more urgent, these are going to want to go to your oncologist. But if you also need to discuss test results, including imaging or any treatment changes, these questions should also go to your oncologist. Kind of the big thing in pharmacy is that we are not allowed to diagnose. So anything that is involved in your diagnosis should really go to your oncologist. And then lastly, we're going to wrap it up with some drug-drug interactions. So drug-drug interactions are when two or more medications affect each other. This can cause problems in how one or both medications involved in the drug interaction work. So it can work too strongly, the medication, they can work not at all, or they can cause these additive side effects that can cause a lot of toxicity. Some of these interactions are minor, and we're just going to kind of monitor, but others can be serious. So why are drug-drug interactions so important in cancer care specifically? So oftentimes because of these, big, because you're on so many medications while you are getting cancer treatment, it's more likely that you're going to get drug interactions in general. The more medications is always going to lead to more drug interactions. It is critical that patients' cancer treatment is effective and avoid side effects. So we want to avoid side effects by those drug interactions that may cause those additive side effects. And we also want to make sure that your treatment is effective. Also, for specifically patients that are more so on chemotherapy, it can cause weaker immune systems, or some of even the targeted therapy or immunotherapy can also cause organ dysfunction, which then makes these drug-drug interactions even riskier. And then lastly, chemotherapy and supportive care medications have very narrow safety margins. So even messing with either the concentration of the drug, meaning the levels of the drug go higher or lower in your body, can really affect both the side effects and the effectiveness of the drug. So how do Sophia and I track for drug-drug interactions? We typically review your medication list regularly when we first meet you, whenever you start a new medication, whenever we do a reassessment phone call to make sure nothing has changed. We use a clinical software and up-to-date references. This is typically not available to the general public, but once again, we always want you to work with your clinical team to prevent any problems before they happen. So if you start a new medication, please reach out to us and we can always do a drug interaction check for you. So once again, what can you do as a patient? We want you to always share your full medication list. So this is not just the prescriptions that are prescribed to you, but also over the counters that you take, herbal products, etc. So please let us know if you start a new medication or supplement, and ask questions if you're unsure about starting a new drug. If you have any side effects of symptoms quickly that occur, we want you to report these to your medical team. And that is all I have today. I'm going to hold all questions until the end and let Sophia talk a little bit more about herbal interactions.
You, Corinne. Up the other slide deck. All right, can everyone see the slides? Perfect. All right, so Corinne already kind of went over our general scope of drug interactions. I'm going to focus a little more closely on our herbal supplements. So the title of this short presentation is Herbs and Drugs, Navigating the Garden of Drug Interactions in Thoracic Oncology. Just a little agenda where we're going. So I'm also going to introduce myself so you know who I am. I'm going to talk about some mechanisms of action and how those impact the drugs and the herbs we take. And then I'm also going to go over some of our commonly used herbal products and what those potential issues are. So this is me. That's a picture of me on my first day of work a couple years ago. So I went to Michigan State and I got a bachelor's degree. It's not necessarily required for pharmacy school entrance, but that is where the route I took. I then moved to Chicago and got my doctorate of pharmacy. For residency, my first year, which is that general residency that Corinne talked about, I did it at the University of Illinois at Chicago. I stayed, that's where I got my doctor of pharmacy, and I stayed on for my first year. My second year, I moved down to Florida and I went to Moffitt Cancer Center. And again, that was my oncology specific residency. So Corinne and I job share, essentially. We cover we split there's 9 physicians at Penn. We split the group in half. So she covers half of them. I cover the other half. So I am also one of the thoracic oncology clinical specialists. And like Corinne, I also got my board certified oncology pharmacist, or BCOP. So mechanism of action, what does that mean? So mechanism of action describes how medications or herbal products interact with the body at a molecular level. So they target enzymes or receptors, and that leads to a pharmacologic response, whether that's making the drug active itself or the body breaking the drug down so that you can get rid of it. So as I said, there's going to be kind of 3 broad things I focus on here when it comes to herbals. So the first thing is the metabolism of medication. So again, how our body is breaking down medications into smaller pieces. As I said, it can either inactivate or turn off a medication so it's easier to remove from our body, or there are some instances where the drug you take itself is not active until your body breaks it down and then turns it on or activates it to make it work. This is mainly done by the liver, which produces enzymes that change the chemical structure. So it's some examples, if you've ever heard anyone talk about CYP enzymes, those are things like CYP3A4, 2D6, PGP, which is P-glycoprotein, and all medications differ in which enzymes break them down and how they're impacted by them. So medications and herbal products impact how well these enzymes can also work. So there's 3 kind of definitions I think would be helpful. So a substrate, it's a medication that's impacted by a specific enzyme. So for example, if we say there's a substrate of CYP3A4, it means that that drug is impacted by that specific enzyme. An inhibitor is a medication that makes an enzyme less effective. So typically, if you have something that's like a CYP3A4 inhibitor, it could impact how much of the medication is broken down. So if you have less of the enzyme that's working, you have less of the drug potentially that's broken down, you have a higher risk of having side effects because you have more of that drug in your body. An inducer kind of works the opposite. So it's a medication that makes the enzyme work better, which you would think would be a good thing. But if you're thinking about a drug that's making an enzyme work more, it's breaking down other medications more. So it actually might make the drug less effective and not work as well. So these are why we worry about these things. The next group I want to talk about are medications or herbal products that kind of help ramp the immune system up. So the immune system acts as like the army of the body. So it acts as a soldier and fights off things that don't belong, which include cancer, infection, those type of things. Now you might be getting immunotherapy. So examples of that could be pembrolizumab or Keytruda, nivolumab or Opdivo, atezolizumab is Tecentriq, or durvalumab is Imfinzi. So these are all examples of immunotherapy. How it works is that we know that cancer cells are really good at hiding from the immune system, and the immune system needs some help recognizing those cancer cells. So that's what immunotherapy does. It teaches your immune system, it points to it and says, this is cancer and you need to attack it. The risk is that when we bump up our immune system, there is a potential that your immune system could get too ramped up and then it attacks your healthy body cells on top of the cancer cells, which can lead to side effects. So if anyone's ever said to you, immune-related adverse effect, that's kind of what falls into the immunotherapy realm. The last thing I want to bring up is just because we get a lot of questions about antioxidants. So in general, what antioxidants do is they protect cells in your body from damage. So they remove particles called free radicals, and that keeps your cells alive and healthy. So the potential benefits is that they protect healthy cells, they boost your immune system, and in some cases, they can reduce side effects depending on, again, what you're taking, what's going on. But the concern is that certain types of treatments, such as chemotherapy and radiation, it can actually make them less effective because those therapies work by damaging cancer cells and then leading to cell death of those cancer cells. So if you're taking a lot of antioxidants and you're on certain chemotherapy or you're getting radiation, you're potentially protecting those cancer cells. I'm going to jump into what are commonly used herbal products that Corinne and I get questions about all the time. The first are probiotics. So through each of these slides, I'll have a little green box at the top that kind of is our general recommendation about it. So probiotics are a good type of bacteria that naturally grow in your gut. You can take supplementation or you can eat yogurts and those type of things that can help kind of promote these naturally good bacteria. They're important for digesting food. They help fight off bad bacteria because if you have no probiotic, if you have no of the good bacteria, then the bad bacteria can kind of run rampant and they keep your immune system strong. Where we worry about this is potentially in people that are getting chemotherapy. So we know that many types of chemotherapy will drop our white blood cell count. White blood cells are important for fighting infection. So if you have less white blood cells than is ideal, then you have a weakened immune system. If you have a weakened immune system, then some of these, while the probiotics are usually good bacteria, if you don't have an immune system, then they can also run rampant. So we do worry about in our patients that are on chemotherapies that we call cytotoxic, so drop your cells. We do worry about people being on probiotics because it could potentially cause an infection. In a more controversial way, immunotherapy, we know, is a role with the immune system. We know that probiotics and your gut health also play a role in your immune system. So there's mixed information whether being on probiotics and you're on immunotherapy can be helpful, harmful, and there's not really a consensus as to what's the best option. I would say in general, Corrine and I usually do not have a problem with people being on probiotics and immunotherapy, but as I have up at the top there, it really depends, and you should talk to your medical team because everyone kind of has different opinions about this. The next is cannabis. So there are lots and lots of different types of cannabis. There's ones that are THC, they have CBD, they have combinations. They also come in a bunch of dosage forms. So they can be topical, they can be oral where you swallow them, they can be sublingual, you put them under your tongue, they can be inhaled. They come as over the counter, they can come from a dispensary, or there's actually versions that are prescription that we use a lot for nausea and vomiting. So proposed uses: pain, nausea and vomiting, as I said, people that have reduced appetite, insomnia. It's also used for glaucoma. And then there's some use in epilepsy and other mood disorders. So where our concerns potentially can come from, there's some potential short-term side effects that we can think of, like dizziness, dry mouth, can cause some disorientation, sedation, that type of thing. But there are also potential drug-herb interactions. So we're calling cannabis our herb here. So it can impact some of those enzymes that we use to break down other medications. So I have them listed here: 1A2, 2C9, 2C19, and that PGP enzyme. There's also studies that look into cannabis use with immunotherapy. So again, kind of how it impacts our immune system. There can be issues with warfarin. And then, as I said, short-term side effect can be sedating or make you tired. So if you're taking it in combination with other medications, we can worry about that. Again, we want you to talk to your healthcare team, but generally speaking, Corrine and I don't usually have a problem with this, but if you have lung cancer, we're really cautious. We do not want you smoking it. So anything that's going to impact your lungs, especially with someone who has lung cancer, is definitely something that we worry about. Biotin. We get lots of questions about biotin. Biotin is just vitamin B7. So it's used a lot for hair and nail health. It can also help with some skin issues. And there's been some studies looking into whether it helps with multiple sclerosis or MS. It typically doesn't have that many side effects. It typically doesn't really have a lot of drug interactions. Where this could come up is that it could have some interactions with your lab tests. Now, it's not typically an issue with newer generations of labs, but if you're getting an older test looking at your thyroid function, it could potentially impact that. Troponin, which is used to measure things with the heart, there's certain pregnancy tests, and you can see there's like other hormonal and vitamin D testing that maybe could be impacted if you're taking biotin. The only thing you need to do is just let your team know that you're taking it, and we usually say this is likely safe to take. Ginkgo, or Ginkgo biloba. So this is a tree that has fan-shaped leaves. Now, when you're taking a supplement, you're usually taking the leaves because the seeds in the plant themselves are typically toxic. There's a lot of people using it for memory, or people that have dementia, or those that get whole brain or any other, brain radiation to kind of help with the memory. It can also help with hearing loss potentially and ringing of the ears. And then there's some reports of it being used for circulation. Potential side effects include bleeding and then more of those skin reactions. Some drug-herb interactions that we worry about here would be with CYP3A4, which is a major enzyme that we worry about. It can also impact 2D6, 1A2, and PGP, but there's conflicting reports. Because it has that side effect potentially of causing bleeding, we really worry about our patients that are on anticoagulants or antiplatelet medications. So I have some listed there that you might be on. And then along with that same bleeding risk, when you're on NSAIDs like ibuprofen, naproxen, those also we worry about. So this one, it depends. Recommend talking to your medical team. Ginseng is another one that comes up a lot. The most important thing I want you to take from this is when you're going to ask a pharmacist about ginseng, know what type of ginseng it is, because there's a couple different types. So the most common are American, Asian, and Siberian, and they all have different herb drug interactions, and they all have slightly different uses and potential side effects. So in general, people take ginseng for strengthening their immune system, for energy, and just keeping up, maintaining their life. And there's potentially some use in diabetes. Side effects could include bleeding. So when we talk about our herb drug interactions, again, we worry about those anticoagulants and antiplatelets with the bleeding risk because it can be synergistically causing maybe low blood glucose. We worry about you taking it with insulin if you also have diabetes, if that's what you're using it for. And then it also can be impacted by CYP3A4, which is one of the most common enzymes we have for our medications. Ashwagandha, it's also known as Indian ginseng or winter cherry. People use this for anxiety or stress or insomnia. Side effects, drowsiness, which explains why they use it for insomnia. But this medication can impact your liver. So if we want to make sure that if you're taking this, that we're checking your liver labs to make sure that everything is okay. It can cause some GI upset. So whether that's nausea, diarrhea, it can cause some like pain potentially. And then it can also impact your skin as well. Again, it has that CYP3A4 or 2B6 substrates. And then because it can cause that drowsiness, we worry about you being on multiple medications that can also cause drowsiness. So another one we want you to talk to your team about. Turmeric. Now, this is a very common one we get questions by. I want to highlight by saying that when we're talking about turmeric, we're not talking about when you cook with it or you're using it as part of your diet. We're talking about when we're taking extra supplementation, usually in pill form or any other way like that. So curcumin it's an antioxidant. It's used for infection, allergies, and all around inflammation. So that's a lot of the reason people take it because it's an antioxidant. Concerns, it also can impact your liver. It can cause skin issues. And there are actually some reports of it dropping your cell counts, which we definitely worry about if you're on chemotherapy. It has, a handful of those CYP enzymes that it could interact with. Anticoagulants we worry about, especially if we're decreasing our cell counts. And then the big thing with this, as I pointed out earlier when we had that antioxidant section, is that because this is an antioxidant, there are potential that it could impact your chemotherapy and your radiation. So I listed out some of our cytotoxic chemotherapy, so that the ones that drop our cells, there's potential that there's risk that this could impact it. So that's why we want to know if you're on it. St. John's wort, it's a plant with a yellow star-shaped flower. People use it for depression, anxiety, and insomnia. It's also sometimes used for menopause. This medication can cause you to be more sensitive to the sun, and so it can cause skin issues. It rarely can cause an interaction or cause a syndrome called serotonin syndrome. We typically would see this on someone who's taking St. John's wort and an antidepressant or a medication called a triptan for migraines. When you use these together, there's a lot of serotonin, so we worry about this. It's a very rare syndrome. It's not something I want someone to be worried about, but something to be aware of. The other thing is it can do something called radiation recall. So if you ever had radiation to your lungs, to your brain, to your bone, anything like that, this medication can actually kind of reinvigorate that and cause symptoms again of having radiation. So it also has major drug interaction issues. So a lot of times if you're talking to a pharmacist, they're going to tell you avoid, potentially grapefruit, and then they'll say St. John's wort. This is like one that we talk about all the time because it does have so many issues. You might want to avoid it if you're on antiretrovirals. So if you have HIV or AIDS, if you're on antivirals for something like herpes or shingles or anything like that. And then again, something we want to avoid with our cytotoxic chemotherapy and radiation. Salt palmetto is used for BPH, and there's studies looking into it for prostate cancer potentially. It can cause, again, some GI upset, some fatigue, headache, and then it can cause some issues with libido or your sex drive and erectile dysfunction. So there's again, handful of enzymes that we worry about with this. It can impact, again, your anticoagulants and antiplatelets. And then this one can actually impact if you're on birth control or you're taking estrogen, this can mess with it as well. So again, talk to your doctor. Turkey tail, we get a lot of questions about. It's a mushroom that grows in stumps. It's actually pretty common in, just like the woods. And a lot of times people are using it for cancer treatment. I want to point out that we don't have any really robust and well-studied trials that are looking specifically at this. So Corrine and I will never make comments about the efficacy when it comes to cancer treatment. We're really looking at all of these as a way of, are they safe? So this one's not really a drug herb interaction issue. Maybe can have some issues with tamoxifen, but we worry about the side effects with this because sometimes they overlap with some of our chemotherapy and targeted therapies, so that it gets kind of a cloudy picture. We don't exactly know what's going on. So it can cause dark colored stool, which can be mistaken for having blood in your stool, because sometimes it is a similar color. The GI upset if we don't really know what's going on. Are you nauseous from your medication or from this? And then it can cause some nail changes as well. In summary, the big thing I want you guys to take away from this is that we always want you to check with your doctor or pharmacist before starting a new herbal supplement. And just because it's natural doesn't necessarily mean it's safe. The mechanisms that herbal products impact other medications or treatment varies. And this presentation is referring to supplementation, not dietary. So when I say antioxidants, I don't mean you can't have orange juice. So that type of thing. The safety of supplements depends on a lot of factors, so how you're taking it. Like, for example, with the cannabis, we don't want you smoking it when you have lung cancer. What else are you taking as far as drug-herb interactions, your organ function? Because like we said, some of those impact your liver, some of them affect your kidneys, so they might not be safe for you specifically to take. Depending on the type of cancer you have. So if you also have breast cancer, there are a lot of supplements that we want you to avoid, especially if you have hormone receptor positive breast cancer. Same with prostate cancer. There's some other medications that we want you to avoid if you have prostate cancer. And then the last is the type of treatment you're getting for your cancer. So if you're getting chemotherapy, you're getting radiation, and then some of our targeted therapies, they also could potentially have interactions with some of these. So Corrine and I are available for questions now. Try and pull up the chat here.
Thank you for the information. If you can stop sharing your screen, then we can get into Q&A. I want to thank you very much for all that you guys have provided to us. What's interesting to me is that a lot in our group, Facebook groups, and talking to other patients, we typically get a lot of information that sometimes, supplements and stuff like that will help with things. And I think that we need to stress the fact that please tell your doctors what you're taking. It doesn't matter if it's over the counter stuff you can pick up at your pharmacy. But first question I want to ask you before we jump into the chat questions is, how often do you see patients? Do you ever, or do you just see the PAs that go to the patients? I mean, how often would it be?
Yeah, so I think that kind of depends on the week, and it also depends on like what capacity. So how often do we see them in person? I would say that I do like a few inpatient teaches per week. Sometimes I get pulled into a patient, but right now we don't have any formal visits with patients. A lot of our patient care is done over the phone, actually. So we're oftentimes calling patients, checking in and seeing how they're doing, scheduling a teach over the phone to review their new medication that they're starting, whether it be a targeted therapy, etc. But that is where I feel like most of our patient interaction is occurring.
So I'll give you an example. Examples are, we are in TKIs, right?
Yes.
Which you guys are aware of. And a lot of them cause muscle pain, fatigue. And then a lot of us have high cholesterol, which makes us take Crestor or something like that. And when you read the side effects of all these medications, a lot of them have the same side effects. So then the big debate is, do I go down on my TKI? And what happens with my Crestor, and what's causing my muscle pains? So can you, any way that a pharmacist can or a physician can sit there and say, one thing has one thing to do with another, or is that a tough answer to come up with?
I think it'd be a tough answer to come up with to specifically blame one agent or the other. They should be monitoring what is called your CPK levels if you're experiencing any muscle cramps or pains. I'm typically fine with patients taking like over-the-counter like Tylenol or ibuprofen as long as their liver or renal function is okay. I know it's not the best answer, but it's kind of difficult to determine which is causing.
So muscle pain, there's a huge debate in our forums. What do we take for muscle pain over the counter for the liver? That doesn't, so not hard on the liver. Tylenol, Advil, Motrin, what is it?
You can kind of take whatever works best for you. I've heard some patients even say, because I know that with some of the ALKs, sometimes they get joint pain as well, like Voltaren gel that you can get over the counter also can help sometimes.
Yeah.
Brought up Crestor, so that's a really great segue as we talk about drug interactions, is that the reason that most of you are on Crestor or rosuvastatin is because there's a drug interaction with atorvastatin and lorlatinib or Lorbrena. So that's a big part where Corinne and I jump in also. We know almost certainly that people that go on lorlatinib are going to have an increase in their cholesterol. So we will do a preemptively check everyone's medication list to see, are they already on one and should we switch them right away? So that is something. It's typically that what's going to happen is it's just going to make it, the lorlatinib is going to make your statin not work as well. And we already know that it's going to cause you to have high cholesterol. So we want to make sure you're on the best statin that we can go up to the highest dose, and it's going to have the most benefit. So
are you behind the scenes basically that are talking to
a lot of times we're
physicians
behind the scenes. So in our clinic, a
Mhm.
lot of times what happens is our physicians will come talk to us. They say, we're going to start this patient. We think we're going to start them on this. Do you think that's a good idea? We'll run like, for example, before lorlatinib and the Crown data came out, and there's still some controversy about where's the best place to start. We don't have like the exact answer. There was lorlatinib, alectinib, and brigatinib, and there were a lot of options. And sometimes there's not a right answer of which one's the best one to start. It's it's not a one size fits all. Everyone's a little bit different. So it made sense for us to check for drug interactions to see if there was one that was better than the other as far as that patient specifically. So they come in, they talk to us, we run an interaction check. A lot of times in our clinic, we are pending the orders for our physicians to sign. We'll talk about what dose they want to start at. So a lot of our physicians will start the lorlatinib at 75, but some of them start at 100. And so we also get roped in a lot of times like, okay, this is what someone's lipid panel came back with. Do we need to dose reduce? Do we need to add in another agent? Do we need to hold them? That type of thing. And we are able to kind of work through that. So we get messages through our electronic medical record. We have patients call us on the phone. Our patients we talk to, they have our cell phone numbers. And then our providers will also come. We sit with them right next to them in clinic. So they just come in and sit with us in between when they see you guys. So we're there. We don't always pop in, but a lot of times when there's a patient I've been talking to a lot, I'll try to come in if I know they're coming into clinic just to pop in and say hi so you can put a face to the name.
Well, we have a good question here. How accurate is drugs.com for finding interactions to prescription supplements and food?
Yeah, I would say it's potentially a good place to start, but I would not use it as your like be all end all source. We use, like Corinne was saying, the sources that we use are typically not available to the general public. They require a subscription that like University of Pennsylvania has access to that we then use. So that's really where we get all of our information from. I have absolutely no problem when a patient's looked it up themselves and they're like, is this okay? I love that you're taking ownership of your own care and you want to know these things, but I wouldn't say that to treat that as like your exact, this is what I have to do. And I also saw that someone asked about Memorial Sloan Kettering's About Herbs.
Yeah.
That's a really good one. That is actually one that we also use. So for herbal products, we use two different ones. One is a subscription, again, that we get through our health system, but the other we will look at is the Memorial Sloan Kettering one. And that one is really good.
Okay, so let's stay on supplements for a while. They're easy to get. A lot of people take them. They don't report them to their doctors because they're embarrassed or whatever it might be. So what's your advice to us about doing that?
I absolutely don't want you to be embarrassed. You saw in the poll, there's lots of people that are taking 6 or more supplements. It's very, very common. My recommendation for anyone that wants to start a supplement, before you buy it, because they can be really expensive, take a picture of it, like the exact product you want to get, and ask your doctor. If they have a pharmacist, they are absolutely going to be like, I have no idea. Let me ask my pharmacist. So Corinne and I get pictures all the time of supplement bottles. And then we use the MSK, the Memorial Sloan Kettering About Herbs, but we also, the other program that we use, you can actually put in the product name. And if it's built into the database, it'll run the entire ingredients list, because a lot of times these herbal products aren't just like one thing. They're like multiple combinations of things. And so when we answer questions about herbal products, as I said, we're answering, do we think it's safe? We're always going to give you the final say, the authority to be like, I want to keep taking this. And that's completely up to you. We're just going to talk to you about the safety. Is it going to impact your cancer treatment? Is it going to impact your organ function?
And you went into depth a little bit about the CPY, and please explain to them, because I gave you a list for an email. We were going back and forth with this email. I don't think people realize that a pathway that your drug goes through might interact with another, something else they're taking over the counter.
Yeah, absolutely. So I look them up all the time. I am always, no matter if I know the answer, I'm looking it up because, things shift. And so alectinib is considered a minor CYP3A4 inhibitor, or I'm sorry, it's a substrate of CYP3A4. So what that means is that if you're on a different medication that is impacting CYP3A4, it can change how your body is breaking down the alectinib. So you might break down less of it so that you have more drug and it's causing more interactions and can be causing more issues. Or someone could be taking a drug that is increasing the amount that enzyme is working and it's breaking down too much of the alectinib. So then this is where Corrine and I come in. Before anyone starts a medication at University of Pennsylvania, we are running interaction checkers usually twice, once right when the order is starting to get processed and then once right before we call you. And so we talk to every single patient that started on a new oral and we go through how to take it, side effects, we talk about drug interactions, and then we answer questions kind of in like an individualized one-on-one. And then they get our phone numbers and they can call us if they start any new medications or have questions or side effects. And a lot of times we're slightly easier to get a hold of than just like the general clinic team.
Okay, let me go into some questions here. Muscle cramps, any idea what you would prescribe to someone who has muscle cramps from these medications?
Yeah, unfortunately, everyone's a little bit different. There's not like a silver bullet for this. It's going to depend again on how are all your other organ functions. Do we have more of a kidney issue? Do we have more of a liver issue? Do we worry about you because you're on anticoagulants and we don't want you on NSAIDs? Or do you have other cancer pains that are, let's say you have bone metastases, and then so you're already on something like morphine or hydromorphone. There's potential drug interactions with some of our opioids and some of the different oral targeted therapies. So again, it's so personalized, which is great and also makes things very challenging, which is why Corrine and I have a job.
So who do they talk to?
I was gonna say, some people are talking about magnesium. There's so many different types of magnesium. Is it a different interaction for each, for like oxide, glycinate, and do we have to check with like every different type of magnesium?
Usually the interaction is with the magnesium as a whole, but whenever someone tells me they're on magnesium, I ask them specifically which one it is. And they all have different, slightly different side effect profiles too, and they're kind of used in different ways. So like some of the magnesium products are going to cause more diarrhea likely than other products type of thing. So again, we want you to be as specific as possible. So that's why I said like what the ginseng, someone's like, I'm taking ginseng. Like I need to know exactly what type of ginseng.
So for exhaustion, what would typically be provided, like Provigil, or give us some names of drugs that maybe people can ask for to the physicians if they're feeling exhausted from the TKI?
Yeah, fatigue is really tough. So even outside of the ALK world, whenever we talk about any treatment for cancer, we pretty much are going to talk about fatigue. What Corrine and I say, which always sounds counterintuitive and potentially frustrating, is that the best thing you can do to combat fatigue is try to stay active, which again, I know can be really tough. If it's wiping you out so badly that you can't get out of bed, that's absolutely something your care team wants to know, and something that we always talk about before we even start any talk about side effects is that do not hide your side effects from your team thinking that I want to stay on this drug, it's what's going to save my life. There's so many studies done for a dose range, and we will never pull you outside of a range that's still efficacious and treating your cancer. So we want to know. Some things, there's not really a silver bullet for fatigue either. Some people get put on medications that can kind of like bump up your energy, but there's nothing really great for it, I will say.
And a hot topic in our group is GLP-1s. Any idea have you seen patients on GLP-1s with TKIs?
We've seen plenty of patients on GLP-1s and TKIs. I think overall, I ran a drug interaction check just now when I saw that question earlier. Specifically with bergatinib and lorlatinib, the concern is the blood sugar. We're just going to monitor these types of things. We're not necessarily going to tell you not to take it because of this drug interaction. So within drug interactions, there's kind of different types of categories on how severe they are. In LexiComp, which is this software that we typically use, it kind of goes A, B, C, D, and X. So this is a C, category C interaction, where we would just have a little bit of increased monitoring. That doesn't necessarily mean that we're going to change therapy. We're just going to monitor that blood sugar.
Things that I do always like to point out about our GLP-1s is that in the studies that they were looked at, they excluded people that have cancer. So that's not to say that you can't take it because you have cancer. It's just saying that when we talk about how we can apply this to our patients, we have less knowledge than we would someone that did not have cancer because those people were not in the study. The first thing I do is I make sure that they fit the criteria. So you have to typically be above a certain BMI. And there were studies that showed in rats that it potentially caused an increase in thyroid cancers, but they've not found that in humans. So I typically don't have a problem with someone being on it as long as we know what's going on. And it can cause, again, some of that GI upset. So as long as we're able to differentiate what is caused side effect by the GLP-1 versus what's caused by your cancer treatment, I typically don't like when people start them at the same time. That's when I get a little nervous because I want to be able to kind of differentiate.
Right. So a lot of us, we don't have immunotherapy treatment with our type of cancer. I know you mentioned in your slides. This is a general question. I don't know if you really can answer, but what vitamins should we avoid on targeted therapies? I think you went a little bit into that, but there's so many different things that you brought.
Yeah, there's not really, like you talked about, when you're on chemotherapy, we say no antioxidants typically. When you're on immunotherapy, we say it depends on kind of what's going on, but there's not really one specific. I would say St. John's wort. If you're going to like pick one that I don't want you to be on, just like generally, that one just has a ton of interactions with like everything. All the other ones I would say, just check with us. We always check. Again, this topic would be very different if we were talking to breast cancer patients, and some of you might also have breast cancer. But if there's a whole list of them that potentially have estrogenic components to them, which can make anyone that has hormone receptor positive breast cancer worse. So there's nothing specific except for I would say if you're going to pick one that I really don't like, it's St. John's wort. I usually can point that out and say that's going to be a problem somewhere in here.
I know this isn't your department, but you did mention that we have a lot of financial issues with our drugs, right? You know, it's very expensive. How do you interact with hospitals and other places that we're in where I'm sure Penn has grants and other things that you do, but do you interact at all with the finance end of it, or?
You do a little bit. We do a little bit. So basically, we have a financial advocacy department within Penn, where we are able to refer patients if they're having difficulty paying for their medications, and they can report their income information, and based off of that, Penn is able to provide support for that copayment. There are other programs like patient assistance programs where it's typically our triage nursing staff that kind of works on you with that, gets all the paperwork sent out to the drug companies, and they can help subsidize the copay through the drug companies. So there's kind of two routes. And then obviously within 2025, if any of you are Medicare patients, the total copay has gone down significantly, down to $2,000. I've heard for next year, I think it's somewhere around like 21 or 2,300 for next year. So hopefully that maintains.
Most of us who are on Medicare are under 65. So I think that we don't have our plan coverage isn't for drugs. So we have to get a commercial plan, which is a problem.
Okay, yes.
So, yeah,
So the commercial plans, if you have a strictly commercial plan, there's copay cards, which Penn itself has its own specialty pharmacy, and they have a really great support team of technicians and staff and community pharmacists that work in our specialty pharmacy that will apply copay cards for you. The other thing is that we have, as Corinne said, the financial advocacy group, they look for grants. So there's kind of like behind the scenes, there's a lot going on. Corinne and I also are involved in the prior authorization process. We are typically not the ones submitting the prior authorizations, but we get lots of questions from our technicians that are submitting them about what is the indication, what makes sense. And if something gets denied, Corinne and I are usually the ones fighting for the drugs. So This is not like, when you think about anyone that you're talking to starting a new specialty medication, I don't want you to think of it as like a regular medication. Behind the scenes, there's a lot more that goes into it than just your doctor sending over a prescription and you picking up. So we have to fight with the drug companies to get it. So it's never going to be instantaneous. So you're gonna have to give us a couple days to get it all together, as from a financial perspective and from an approval perspective.
I mean, we're such a strong group that we even contact directly the pharmacy and the Genentech, Pfizer, et cetera, for reporting side effects and getting information from them. But you guys are out, you talk to them directly. I mean,
Exactly. And we
patients,
have contacts at all the major drug companies, and we have contacts at all the major specialty pharmacies. So if they can't fill with us, which would be our preference, so there's a lot more transparency on our end of what's going on. I have a direct contact at ALKtALK. I have a direct contact at Optum. I have a direct contact at CVS Specialty. So a lot of times when I talk to my patients, I'm like, you start out, and if you get caught up in something, let me know, and I can kind of jump in and try to figure out exactly what's going on. So Corinne and I kind of act as the intermediaries, I would feel like, between our patients and their healthcare team. We kind of are the boots on the ground. We're able to kind of figure out what's going on more from a patient level than just like a treatment level.
Great. Dana, do you have any questions that you see?
No, I was just noticing that somebody's asking, is grapefruit contraindicated for all TKIs, or?
It's not all TKIs. They're specifically called out for certain TKIs. But if you're on a statin, you should not be on grapefruit juice. So no grapefruit juice, no grapefruits. Squirt technically is grapefruit flavored, which I didn't know until I started this job and learned that. So it's not across the board.
Right? Also,
yeah, yes. Sometimes Seville oranges are also an issue, which is not like a regular orange, it's like a specific type of orange. And some star fruit potentially also sometimes is. So again, this is where Corinne and I come in handy, and this is why we have jobs, is to make sure that there's no issues with any of these things. But as like a whole, no, it's not that everyone has to avoid grapefruit. It's not always specifically called out, but sometimes in the package inserts, they specifically do mention grapefruit or grapefruit juice. So any of our patients, if we don't say it, then you are probably good to go, but we always do point that out if that is one of the things.
Did you see the question in regards to mushrooms? I can't even pronounce it. Rensi and Kubaki mushrooms are better for cancer. Can I take mushrooms and be cured, or what?
So I will say there are no good, we call them randomized, placebo-controlled, robust studies looking at, is this effective for cancer treatment? Now, it's definitely something that's being looked into, but right now we have no consensus about, is this going to be beneficial or not? So again, when Corinne and I look at things, we're less looking at, is it going to fix something? We're more looking at, is it going to cause a problem? So if you want to try mushrooms and you think that's going to be helpful, I'm all for it, as long as it's not going to interfere with something else that we're doing.
That could go hand in hand with medical marijuana, I think. But,
there was also a question about statin. Some people want to avoid taking a statin. Do you recommend anything herbal? Is there any studies that you've seen that would recommend anything herbal you could take for a statin?
There is an herbal available, but specifically with lorlatinib, induced hyperlipidemia, I wouldn't recommend the herbal, just because you really can see such severe hyperlipidemia and hypertriglyceridemia with lorlatinib specifically. So there is an herbal available. It actually mechanistically works very similarly to a statin though, so I would prefer just to use the statin that has been clinically
Our concern is that if anything gets too high, we have to hold the lorlatinib. I think everyone kind of wants to avoid that. So yes, we usually say statins. And if your triglycerides are a problem and your cholesterol is fine, sometimes like fish oil can be helpful. Again, I think it's best to check with, as I said, that's the big moral story, is just check with us. Again, we have no problem. If it's not going to cause a problem, I'm always go right ahead. I can't tell you if it's going to help all that much, but as long as it's not going to hinder your treatment, then I'm all for trying. But I don't want you to spend a bunch of money on something and then ask, and then I'm like, well, there's a problem here, because I know how expensive they can be.
Magnesium salt. Do you know which one, if they work, number one, and which ones would you recommend for leg cramps?
there are not great, again, we don't have great studies on any of these things. So anything that we'd be recommending would be give it a go, because we've anecdotally heard that it can maybe help. My concern with magnesium, with any magnesium product, is that it can cause diarrhea. So yes, you can try out the magnesium product, but if it causes diarrhea, then that's going to be a big issue, because we run into this issue where people get diarrhea and then we prescribe them something and then they get constipated, and it's like this back and forth issue. And it's really impacting their
How about
quality
like
of life.
Tiger Balm,
You're right,
Bengay?
I was going to, hold on, sorry, Mark, but you're talking
Okay.
about diarrhea, that magnesium causes diarrhea, but a lot of our medications cause constipation.
Right.
So
So
magnesium sort of like,
it could balance out. A lot of times we talk about that
Okay.
too. So we talk about, especially people like medications that cause constipation, if people are cause diarrhea, and then people are on opioids for pain. We hope, my goal is that you're going to even yourself out. So my other thing I say is that, like, you know your body best. The other thing I usually say before anyone starts a medication is take kind of like a mental note of how you feel. Like, this is my baseline. And then noting any changes that pop up. When Corrine and I counsel people, we try, if we can, if we have the information, to give you like an estimate of when we would expect certain side effects to pop up. So like, we know those changes in cholesterol are going to happen in the first month. They can happen beyond that also, but we know that they pop up pretty quickly. So in our clinics, we bring people in 2 to 3 weeks after starting the medication and recheck labs.
Great. I know we're over our time, but any final words from Corrine or you, Sophia? Any last words to the patients, like what we can do to advocate for ourselves?
I don't have any specific words, but I would just make sure that you are really utilizing your whole entire oncology team. Realize who is on your team. I know that, especially in some smaller healthcare systems, you might not always have a pharmacist available, but really use your whole entire healthcare team. Ask questions, really speak up when it comes to the side effects that you're having, so that we can hear about them and we can manage them.
Yes, we don't want you not saying something because you're worried that it's going to impact our decision on what we're doing with your care. We are here to support you. You are the center of everything we're doing. You're the nucleus of our entire team, and everything that we do revolves around you. So we just want to make sure that we are doing the best we can. And the best way we can do that is just you guys being open and communicating with us. And Corrine and I are both really happy to be here and to meet all of you, virtually. So, and, give us a little plug for what your pharmacist does.
All right. I didn't realize you guys were behind the scenes, but my takeaway was don't be shy. Tell your doctor everything. Don't hide all these pills they can buy at CVS and other over-the-counter places, and believe your fellow cancer patient. Make sure you tell your doctor what you're doing. So
Also,
thank you so much.
sorry,
Yeah,
just
go ahead.
one last thing. It can cause a lot of financial toxicity too, just trying out all of these supplements. So it's really best just to check in with us first, because we don't want you spending more and more money on all of these things that may not work or may interact.
Good point. Dana, I'm gonna let you close it out and tell us a little plug for our Healing Arts events and stuff that we have, not just the events, but the whole program itself.
Yeah, I wanted to say thank you so much to Corrine and Sophia for coming tonight. Yeah, our Healing Arts, that we now have offerings. We have some stuff at night. We have stuff on Saturday. So please come check it out. We are definitely stronger together. This community makes such a huge impact in our lives. Having somebody who truly understands like what we're going through, and we can guide each other to call your doctor, that. And I'm not going to say that our meetings, that anything you hear in our meetings, don't take as medical advice, but we'll constantly be telling you to just bring it up to your doctor and give you that that little boost that you might need to not just tell us, but to tell your doctor. And
we give emotional connections to each other. So
oh yes, the people in this group are my friends. I didn't know how much I needed them until I was in this group, and they are definitely all my friends. So So I wanted to thank everybody for coming, and thank you so much to Corrine and Sophia for giving such wonderful talks tonight and helping us out so much. And if everybody wants to unmute and say thank you to our guests, that would be lovely.
Thank you.
Thank you.
Thank
Both of
you.
That was
Thank
great.
you.
Nice presentation.
Great
Thank you.
presentation.
All right.
We will-
Thank you everyone for coming in on Sunday, and we'll see you soon. And maybe I should transfer to the University of Pennsylvania. What do you think?
Take care, everybody.
All right, take care, everyone.